So the condition I chose is sepsis, and I picked it specifically because we tend to treat it as a purely clinical emergency. But when you look at who's actually getting it and why, it tells you a lot about how our health systems work and who it isn't working for. In Aotearoa New Zealand, Māori and Pacific people are experiencing sepsis at more than double the rate of everyone else. That's what this map represents. Not pathophysiology, but the structural reasons behind that number. Starting at the top, housing, overcrowding specifically, because that's the mechanism. When multiple families are sharing one house, what you're also sharing is airborne pathogens, respiratory infections, skin infections, meningococcal disease, the things that progress into sepsis when they're not caught early. The WHO Housing and Health Guidelines, Shannon et al., 2018, make this link explicit, establishing crowding as a direct risk factor for the kinds of infections that deteriorate into sepsis. And the numbers in New Zealand are significant. EHINZ 2023 data shows nearly 40% of Pacific households and just over 23% of Māori households are classified as overcrowded, compared to 3.5% of European households. That's not random variation, that's a structural outcome. And why does this gap exist? Largely because of the economic consequences of colonisation, land alienation, the erosion of tino rangatira, which I'll come back to. The short version is, this didn't happen by accident. Now, income and poverty. Notice the dashed arrow connecting this back to housing. Poverty is what forces families into overcrowded situations in the first place. So these two aren't separate problems, they're compounding each other. 42% of Pacific New Zealanders live in the most deprived socioeconomic decile nationally. What that means practically is that going to the GP isn't a reflex, it's a financial decision. And if you delay care for what turns out to be a serious infection, you're giving sepsis time to develop. Huggin et al.'s Waikato regional study showed hospitalisation rates for infection were more than double in both Māori and the most socioeconomically deprived populations. By the time those patients are present, the condition is already further along. That's the income to sepsis pipeline, not a mystery, just a predictable consequence. Now bottom left, structural racism. And I want to be specific about what I mean, not individual prejudice, but the way institutions are built and how that produces consistently worse outcomes for Māori and Pacific patients, even without individual intent. Gurney et al. Documented significant ethnic morbidity disparities across virtually all commonly diagnosed conditions in New Zealand, and were direct about the cause: institutionalised racism. In clinical settings, that looks like implicit bias in triage, under-recognition of acuity, and a shortage of culturally appropriate consumer resources. Paul et al.'s ICU audit at Waikato found Māori sepsis patients were younger at presentation, lived in higher deprivation areas, and were overrepresented in admissions. Younger but sicker means the disease is progressing further before care is assessed. Part of that is historically earned distrust of healthcare institutions, and part of it is those institutions haven't always given Māori patients reason to trust them. Now moving to bottom right, education and health literacy. There's another cross-link here. Income to education, because financial hardship limits educational attainment, which in turn limits health literacy. These systems reinforce each other. The NZ Sepsis Trust National Action Plan is direct about this. A lack of public awareness of what sepsis could look like, combined with a shortage of consumer resources in Te Reo Māori and Pacific language, is contributing directly to delays in treatment reaching us. If someone doesn't know that a high heart rate, confusion, and cold clammy hands together are a red flag, they're not calling an ambulance. And by the time they do, the window has narrowed. This isn't about intelligence, it's about access to the right information in the right language. Now bottom centre, geographic access. This specifically in our context as paramedics. The HQSC sepsis shock take identified that out of hospital and primary care settings face the biggest barriers to timely sepsis recognition. Rural communities, which are disproportionately Māori, have longer ambulance response times and greater distance to emergency departments. That time is not neutral in sepsis. Every hour of delayed treatment and septic shock meaningfully increase the mortality risk by 4 to 7%. And the GP co-payment cost functions as a geographic barrier too. It makes the healthcare system effectively more distant, even for people who are physically close to it. Now top left, Te Tiriti o Waitangi and colonial policy failure. I included this note because I think it's important to name the upstream cause rather than just describing the downstream effects. And to be clear, this is a colonial determinant, not just a policy one. The NZ Sepsis Trust National Action Plan explicitly frames its equity commitments through Te Tiriti and calls existing disparities in Māori and Pacific sepsis outcomes avoidable and unjust. But the HQSC stocktake found equity considerations weren't routinely being applied at governance level, and no distinct sepsis clinical pathways existed for Māori or Pacific populations. The plan is there, the institutional follow-through hasn't kept up. The direct mechanism to sepsis specifically is this. Crown failure to honour treaty obligations has left primary care chronically underfunded in communities with high Māori and Pacific populations. Infections that would be caught early in a well-resourced system instead progresses to sepsis before anyone gets clinical contact. And look at the cross-link to structural racism. That's not coincidence, it's cause and effect. Colonial policy failure is what allows institutional racism to keep operating unchecked. So how it all connects. The dashed arrows across the map are showing the system, not individual problems in isolation. It's one reinforcing loop, and there's a feedback loop too, shown at the top of the map. Te Tiriti and colonial policy failure enable structural racism. Structural racism perpetuates income inequitably through employment discrimination and the long tail of colonial land disposition. Income inequality forces families into overcrowded housing, concentrating infection risk. Poverty simultaneously limits education and health literacy. Geographic and cost barriers mean that when infection develops, care becomes too late. And then the feedback loop. Poor sepsis outcomes reduces workforce participation, which entrenches the poverty that feeds back into every upstream determinant. The system is self-sustaining without structural intervention. Young et al. Published in the Lancet Regional Health in 2025 confirmed this. Higher sepsis incidence and mortality concentrated in Māori and Pacific populations and high deprivation communities across 2 decades of data. This isn't coincidence, it's documented causation. As paramedics, we encounter the downstream consequence of this system, presentations that have progressed further than they needed to, because the structural conditions we've just mapped made earlier access to care impossible, not unlikely. That distinction matters. Understanding these determinants changes how I approach that, not just clinically, but in how I communicate, how I advocate, and how I practice in a way that's genuinely culturally safe, rather than just culturally competent. Our Te Tiriti obligations aren't a box to tick. They're asking us to see the full structural picture of why our patient is in front of us, and to not reproduce the same bias and literature we've just cited describes. Sepsis is a clinical emergency. The inequity behind who gets it is a colonial and structural one, and understanding that is squarely within our scope.